and also the SOFA score, whereas Murray lung injury score was worse in the ECMO group in comparison to the non-ECMO group. And the severity of the lung injury in terms of severe lung also more in the ECMO group in comparison to the non-ECMO group. There is a high percentage of associated injury in terms of head, chest, abdomen, and pelvis in both groups. And the complication, acute kidney injury, is higher in the ECMO group in comparison to the non-ECMO group, as well as the multi-organ failures and acute kidney injury requiring hemodialysis and deep vein thrombosis. So these patients are having multi-organ failures and acute kidney injury more than the one with no injury. For the 22 cases who had ECMO, we have a higher percentage with a high risk in terms of the scoring for their RESP score in comparison to the other groups. And also the type of ECMO, majority, 95% were the ECMO, whereas only one patient had veno-arterial ECMO for these. The administration of ECMO, the mean range is 2 days, and it's ranged between 1 to 14 days. And in 13 cases, it was started less than 2 days from the time of entry, and in 9 cases, is more than 2 days. There is no difference in terms of ventilation day, ICU, length of stay, hospital length of stay, and the follow-up. In terms of disposition, there is no difference between the two. The long-term rehab was 54% for the ECMO group versus 30% in non-ECMO, and discharge to home was higher in the non-ECMO group. Mortality, 30 days mortality was overall is close to 57% for the entire cohort, and for more than 30 days mortality was higher in the ECMO group. Cause of death is head injury, multi-organ failures, septic shock, and cardiac arrest are the 4 highest ranking cause of death. In terms of the multivariate logistic regression analysis for the prediction of mortality among the trauma patient with acute respiratory distress syndrome, we found the acute kidney injury and brain edema is the prediction for this group in terms of worse outcome. In terms of the timing for admission to ECMO, we found that the patient who had less than 2 days have a lower mortality rate in comparison to the patient who had ECMO after 2 days of admission. And patient who sustained acute kidney injury has the highest mortality rate, accounting for 54% in comparison to the patient who did not have acute kidney injury. And for the conservative treatment group, patients who had acute kidney injury have 80% mortality in comparison to 25% for patients without acute kidney injury. Based on mortality based on mural lung scoring severity, also we can see that ECMO patients have a less mild to moderate lung injury, whereas mortality is higher in the non-ECMO group, regardless of actually the severity. So the mortality in the severe lung group is still low in the ECMO group in comparison to the non-ECMO group. And also the Kaplan-Meier reflecting the finding. In terms of actually the management of traumatic tracheobronchial injury, we can illustrate this based on a recent publication that we had 3 cases with different injury. The first one is a patient with bronchial injury at 27 years old. He presented to the trauma room after a fall from a 3-meter height. He was having a low Glasgow Coma scale, hypoxic, diffuse subcutaneous emphysema, and the patient was intubated and had 2 chest tubes. And the timeline for this patient, he had VV ECMO on admission, and the patient managed with surgical intervention and a successful repair of the bronchial defect, and the patient was taken off ECMO after 16 days and discharged home without any neurological deficit. The third case with a bronchopleural fistula, a gentleman of 63 years old, brought to the trauma room also after a fall from height. He was initially hypotensive, hypoxic, with decreased air entry bilaterally and significant subcutaneous emphysema. The patient had 3 chest tubes and still had difficulty to ventilate, and therefore the patient was started an ECMO straight away to maintain his saturation, and the patient was supported for 2 weeks, and ECMO managed to come out of ECMO and actually did quite well. He stayed in hospital 62 days and he was discharged to rehabilitation in a good condition. The fourth case is a traumatic disruption of the trachea in a 29 years old patient who was hit by a car, had a massive bilateral pneumothorax with surgical emphysema, required 4 chest tubes and still did not manage to control his emphysema. The reconstruction of the CT scan can clearly demonstrate the area of disruption of the trachea. The patient was stented and put in ECMO and managed actually to survive the event and discharge home with a stent. More recently, we had a patient who had a collapse of a wall on him, and at the scene he was desaturated, intubated, and had needle decompression of the left chest tube, and he was brought to the hospital. He had bilateral surgical emphysema as well as pneumothorax, pneumopericardium, and pneumoperitoneum with a significant leak. So the patient was reported to have possible diaphragm injury, so the patient was taken to the operating room and had laparotomy with negative findings except that there is air. He had also a pericardial window to release the tension pneumopericardium, and he continued to leak from that. The reconstruction shows that there is a defect in the right main bronchus, and also the reconstruction of the pulmonary system revealed that there is an injury to the pulmonary artery. The patient intraoperatively had a bronchoscopy which showed the area of injury in the main bronchus with a clear protrusion of the cartilage within the bronchus, and also there is a bubbling of air in the posterior aspect. The patient was put in ECMO intraoperatively, his saturation improved, but as the surgeon tried to fix this area, he had a massive bleed, and the patient unfortunately died on table due to a disruption of the pulmonary vein just behind the site of injury of the trachea. this, when it happened, we resulted in changing our management in terms of applying ECMO in an acute setting in a patient who sustained cardiac or bronchial or mediastinal injury, and we started to think about a blunt cardiac injury which can result in pericardial rupture, chamber rupture, septal defect, and valvular rupture, or even dissection of the aorta. Given this in mind, we elected to move from applying the ECMO in this setting to moving to the cardiopulmonary bypass setting, which give us more option in terms of intraoperative management of these patients. So this is a case of a iatrogenic cardiac injury, unfortunately happened due to the pre-hospital needle decompression. And this is the patient. He was intubated, he had desaturation, so they put a needle for decompression, resulted in actually injury to the heart. So the patient was taken to the operating theater. He was put in the supine position, and we put him on the cardiopulmonary bypass, and we found that there is an injury to the left ventricle and also to the right side of the atrium, and managed with simple repair, and the patient actually did well after this. The second case, and this is how the thing evolved. This patient is a young individual, had a motor vehicle accident and came complaining of severe retrosternal pain. He had sternal fractures, and EFAST shows that he has a large pericardial fusion, and the patient was taken straight to the operating theater because he was hypotensive. As the patient intubated and the start of the sternotomy, the patient had cardiac arrest, so the pericardium was open, packing, and we put the patient, as you can see, on the cardiopulmonary bypass. Sorry, this is so he had active bleeding from a ruptured right atrium, and require a simple repair for this patient. The other case is a 3-year-old baby who sustained actually a severe trauma resulting in hemorrhagic shock and massive left hemothorax. He was taken to the hospital. The patient was put on cardiopulmonary bypass with hypothermia arrest, and they found that he has isolated left atrial rupture, and the patient had a repair and a successful outcome without any neurological deficit following this. The ninth case which we had is a young patient, a 44 years pedestrian patient, came also in extreme with severe chest pain and hemothorax. On reviewing, you can see that there is a large pneumothorax with a contrast, and there is also large contrast in the pericardium. So the patient had pneumopericardium with right side hemothorax, secondary to a bleed. He had multiple rib fractures as well as sternal fractures. He has also open wound, so the PAT scans show that multiple rib fracture, pneumothorax, and also injury. So the patient was hypotensive, taken to the operating theater with this finding, and the patient had the opening of the pericardium. As we open the pericardium, you can see that there was active bleeding actually, and this is the configuration, and the patient was put on cardiopulmonary bypass with cardioplegia, and the area of bleed was packed here because to control the area. After the packing was removed, we identified that the patient has actually avulsion of the pulmonary vein from the heart, and this was repaired under cardiopulmonary bypass with cardioplegia and cardiac arrest, and then the cardioplegia was reversed, and the patient heart started beating, and we checked the area for any further bleed, and there was no bleeding, so he was decannulated and actually did quite well with no neurological deficit despite the severity of entry. So we thought that this is the way to go for these patients instead of the ECMO, which will give us the opportunity to stabilize the patient, utilize the non-beating heart, and also to give the patient the chance for a good outcome. So to conclude, the ECMO and cardiopulmonary bypass support play an important role in the management of complicated tracheobronchial and cardiac trauma, and the surgical procedure and therapy reduce the risk of mortality. ARDS is uncommon in trauma patients, but it has a high mortality. ECMO use was associated with better survival in patients with severe lung injury according to Morale Lung Injury Score. And time factors, multidisciplinary communication, plan prior to intervention are the key to good outcome with the association of the utilization of ECMO and the cardiopulmonary bypass team. We established cardiopulmonary and ECMO team working together with us in the trauma. The structures as illustrated, we have the vascular access education, vascular access database, the quality and the research, with the cardiothoracic vascular surgeon working with the emergency critical care anesthesia physician, the pre-hospital paramedics, and also the perfusion nurse and pharmacist to deal with the patient need for ECMO and the coordination of the ECMO team to have the best outcome for our patient. I would like to thank you for the opportunity to present and also to invite you for the Qatar Health 2026 in November 11th to 14th. Again, I would like to thank the Emergency Medicine Physician Association of Turkey for their kind invitation to allow me to present in this outstanding meeting.
Okay, thank you very much, Dr. Hassan, and I want to invite the next speaker from Poland, my colleague, very important subject about the airway management. Lucas Zarpak, please.
What is truly new in the airway management in emergency medicine, not just devices, not just new studies, but what is really changing practice at the bedside. And the main shift is we are moving from the device-first approach to the physiology-first approach. In other way, success is no longer about only about seeing the vocal cords and passing the tube. Success meaning keep the patient oxygenated, keeping the patient blood pressure stable, and getting the tube on the first attempt whenever possible. So today I will focus on the topics, on the changes that matter mostly in 2025-2026. I mean that better pre-oxygenation, videolaryngoscopy as a default, smarter drug choice, using the ultrasound, and last but not least, stronger team-based airway practice. For many years we were trained to think mainly about the anatomy. Can I see the vocal cords? Which blade I should use? Do I need a stylet? Do I need a bungee? Or any other rescue device? The question still matters, of course. But now the bigger question is often, will this patient desaturate, arrest, or fail into the shock during our intubation attempt? So, this is the real shift. Modern airway management is not just a technical procedure, it's a resuscitation procedure. So before laryngoscopy we should run quick mental check, as you see on this slide. I mean A for the airway view, B for the breathing reserve, C for the circulation, D for the decision point, T for the team and timing, and C again for the confirmation. This is important because a patient may have an easy airway and still be a very dangerous, easy anatomy and still be in the very dangerous airway. Even beautiful glottic view does not help if the patient crashes during the induction. So the new mindset is simple. First, understand the physiology, and secondly, choose the appropriate airway strategy. If you remember one thing from the guidelines, remember this. Good airway management now means having 4 plans before we start the intubating patient. I mean an oxygenation plan, an hemodynamic plan, a device plan, and a confirmation plan. The ACIP 2025 policy is very practical. It tells us to use non-invasive ventilation for pre-oxygenation when possible in hypoxemic patients. If this is not possible, high-flow nasal oxygenation is a reasonable option. It should also support videolaryngoscopy when it's available, and says apneic oxygenation can be considered also. Just as important, ACIP reminds us to think about blood pressure. In shock patients, for example, etomidate or ketamine are preferred. In other way, fentanyl, midazolam, propofol should be avoided when the risk of post-intubation hypotension is high. On the other way, another guidelines, I mean the DAS 2025 guideline, adds another strong message. I mean by this, keep oxygen delivery going, maximize first pass access, use waveform capnography, and not to keep making repeated attempts. So those guidelines are pushing us toward one clear standard: prepare better, oxygenate better, and make the first attempt count. This may be the most important practice change in the emergency airway care. The procedure does not start when we put the blade between the teeth. It starts when we beginning to build the oxygenation reserve. As you see on this slide, the pre-oxy trial made this very clear. In patients with hypoxemic respiratory failure, hypoxemia during the intubation happened in 9.1% with non-invasive ventilation compared to 18.5% with the oxygenation mask. This is a large difference. and it matters. So, in the right patient, NIF is becoming stronger in the fallout strategy for pre-oxygenation. However, high-flow nasal oxygenation is also useful, especially if NIF is not tolerated or not feasible. But what is important, we should not confuse useful with equivalent. The strongest evidence right now are with the NIF. Another important point is that gentle backmask ventilation during RSI is no longer something we should fear automatically. In patients, if patients need ventilation to avoid desaturation, of course, ventilation is the right move. And the basic still matters, I mean the head-up position, a good mask seal, and the PEEP. And of course, pre-oxygenation should not be a ritual, it should be effective. We are now at the point where the video laryngoscopy is becoming the default device, not a special tool for selected patients. And the reason is not a fashion. The reason is performance. Video laryngoscopy now does not just give us better image. It improves shared vision, coaching, recognition the failure, and first pass success strategy. This is a real value. When we're thinking about the Baji story is also changing. For some time, many people use treat Baji as almost like a routine habit. But the evidence don't support universal use. A Baji is still very valuable in predicting difficulty, rescue situation, and if the hands of clinical, who knows how to use it. But it is not something that must be used in every case. And there is an important safety point. I mean, the blind Baji insertion is dangerous. The whole sign is not something we should rely on because of trauma risk. So the better mental model is video laryngoscopy first, Buji when it helps, and no wasted attempts, because every another attempt makes the next one harder and the patient less safe. Another thing is ultrasound. Of course, point of care ultrasound is clearly becoming more relevant in the airway management. But the key word is adjunct, not replacement. Its best cure and role is not replacement capnography. Its best role is to support decision making, and the support is important word. For example, it is very helpful for identifying and making the carotid membrane before the difficulty airway really big scenario when we can intubate and cannot oxygenate patient. It may also help selected airway assessment and can assist with the confirmation when the capnography is not available or delayed, but we should be very clear, waveform capnography remains crucial, remains essential. This is a gold standard for now. We should not trust misting, chest rise, or acoustation alone. Those signs can mislead us. So the information battle remains simple. Continuous capnography, waveform capnography, plus video confirmation of the tube passing the chords when it's possible. Ultrasound is growing, of course, but the capnography is still number one to confirmation of the correct intubation. One of the biggest advances in airway management is not a new gadget. It's a better team model. And as you see on this slide, the best airway team now works more like pit stop than solo operator. That means a short pre-brief before intubation attempt. What is the oxygenation plan, what is the hemodynamic plan, what is the rescue plan. It means clear rules. Who is operator, who is coaching, who is managing the pressure, who managing the drugs. It means attempt discipline. The goal is not to keep trying. The goal for us is to make the best fair pass. It means rescue rapids. The supraglottic airway device should be open and should be ready. The surgical airway kit should not be someone far away. It should be also prepared. And it means post-intubation care should start immediately. I mean capnography, ventilatory connection, and sedation. And this is modern shared cognitive model. It makes airway care safer, calmer, and more reproducible. This slide gives us a very practical way to think about pre-oxygenation. Before we start laryngoscopy, we should know the physiology, we should ask how much the margin of the oxygen does the patient have and how we can improve it. The escalation ladder is stratified, so start with positioning, head up or semi-fowler when possible, flexible. Then make sure that face mask is going real work. I mean, it's tight and sealed. I'm sorry. And sealed. To consider high flow nasal oxygen, especially when apneic oxygenation may help, or laryngoscopy may be difficult. And for patients with profound hypoxemia or shunt physiology, non-invasive ventilation should be moved much more earlier in our thinking. And as I says about the pre-oxygenation, we have the one more time data from the pre-oxy study, and they are important. We need to remember 9.1% for NIF group and 80.5% for the mass group. This is not a subtle difference. So to take home point is simple. Do not give every patient the same pre-oxygenation just because it's familiar. Match the method to the physiology. This slide captures the model case for video laryngoscopy very well. The main complication in emergency medicine is often not the device itself, it's repeated attempts. So video laryngoscopy improves the opening move because it improves the view for the whole team, not only the operator. The shared screen helps coaching, it helps timing, it helps recognition of when to continue or when to change our course. We see the data from another study on this slide, and the rate of more than one intubation attempt was much more lower with video laryngoscopy in this study comparing to the direct laryngoscopy. This is exactly the direction we want. Of course, there is an important caveat. In heavy blood, vomiting, or secretion, the best device is the one that still works. So this is not about ideology. Technique still matters, context still matters, but as a default starting point, video laryngoscopy right now is very hard to argue against. This is one of the strongest clinical slides in this presentation. In critically ill patients undergoing emergency intubation, video laryngoscopy improves the first success rate from the 70.8% to 85.1%. This is a minor clinical gain. The glottic view was also much more better. Glottic 1 view was seen in 76.3% with the video laryngoscopy compared with only 44.7% with the direct laryngoscopy. And the failure because of pure view dropped sharply from 3 to 7% versus 17.3%. Importantly, severe complications were not increased in better first pass success, better view, fewer visual failures without a safety penalty. In emergency airway care, this is exactly what we want from the developed device. This is why many departments are no longer asking they should use the video laryngoscopy. They're asking how to make it a standard. This slide makes also an important point. In this study, participants intubate the patients with the cervical spine injury scenario. So, in this cervical spine surgery study, the video laryngoscope was slower than with McCoy laryngoscope. But the time is not whole story. The video device gives a better glottic view, lower difficulty scores, easier intubation, and higher first pass success rate. So yes, it took a few seconds longer, but it made the procedure more controlled from our perspective. And in a patient where the neck movement or precision matter, a few extra seconds may be acceptable price for the better condition. It is also a useful reminder for the emergency care as well. We should not reduce airway performance to speed alone. A slightly slower first attempt may be the safer attempt if give us better control, better visualization, and fewer repeated attempts. This is very interesting educational point. In novice operators who perform video laryngoscopy, they lead to faster laryngoscopy times and faster intubation time across repeated attempts. So the device did not just improve the outcome of one procedure. It changed the learning curve itself, and that matters. Because in a real department, not every airway is managed by the most experienced physician in the building. Training matters, and safer learning matters also. The real message is not that novices need more practice. Of course they do. The message is that device can help safe competence appear sooner, and that has implication not only the education, but also on the supervision, and also on the team coaching, and on the department policy. This slide adds one more now-set point. The laryngoscopy, as we know, is not one single thing. Different systems have the different learning curves and the different strengths. In this study, young anesthesiology evidence were tested across several laryngoscopes, and the performance was not identical among those devices. That matters because a department adopts video laryngoscopy. It should not assume that all devices behave the same in practice. Training should be device-specific. Familiarity should be built deliberately. And protocols should fit equipment that people, medical staff actually use. So the practical lesson is to not just buy device. We should build a system around those devices which we have. If I have to reduce the whole talk to the 5 practical changes, it would be first think about physiology before anatomy. Do not ask whether the patient looks difficult, and ask whether the patient is looked to desaturate or collapse. Second, use first pre-oxygenation in the right hypoxemic patients. The next one, make video laryngoscopy your default, but also use the PUSI selectively and skillfully. Choose induction drugs with a blood pressure plan. I mean, do not rely on habit. Think in this way on hemodynamics. Standardized, and last but not least, of course, is standardize the team choreography. I mean the roles, confirmation, rescue, readiness, and post-intubation care, because the modern airway excellence is not simply getting the tube in. It's getting the tube in without playing with the hypoxemia, hypotension, or confusion. We know that AI is developing right now, and it's developing also in the context of airway management. And this slide moves from the current practice to the near future development. The idea is an advanced video laryngoscopy with AI support. It can overlay anatomical clause in real time, estimate the oxygenation risk, and support the operator during the procedure. It can also collect procedural data automatically, which is very important for the quality improvement and training. But for now, it remains an early concept. It's promising, but not yet practice changing. However, we have some devices for it. And this is another very interesting idea on this slide. The divoscope combines with laryngoscopy with motorized tube channel and AI guide glottic targeting. It is simple terms. It tries to make the tube delivery, the airway management, intubating easier, especially in the stressful conditions or for less experienced operators. The practical rules are impressive. The high first pass success rate show median intubating time, lower workload, and no visible injuries. But we need, with this device, we need to stay conscious. There are those data based from the cadaver data, not real emergency patients. So the concept is exciting, but it still needs clinical validation before we know its real value at the bedside. And this is maybe one of the most realistic early clinical use of AI in airway management. The Larynx guide works with the standard video laryngoscope system and helps identify anatomical structures and tube positioning in the real time. In the study shown here, the diagnostic performance was also promising. That suggests AI may be useful as a visual decision support during the intubation. But the key point is this. It is decision support, not decision replacement. The system still struggles when the image quality was poor, when the lens fogged, or when not standardized tubes were used. And most importantly, it does not replace waveform capnography. So the right way to see this technology today is as an assist, not an authority. So to close, the future of airway management is not about one magic device. It's about combining the physiology, the preparation, team discipline, better visualization, and smarter support. This is what changes outcomes. Thank you very much.
Any questions?
Thank you so much for this beautiful presentation. And my name is Dr. Mustafa Altay. I'm from Giresun Training and Research Hospital. Going forward with technology is something terrific, actually. But it has something also in the background. It's what we call the de-skilling. Like, I'm just going to give an example. When we drive the Tesla and we leave the Tesla to drive by its own, that's how we gradually, day by day, will forget how to drive manually. I only have two questions about this thing. One, always, this is from my perspective actually, back to the basics is always better for me. For example, we don't have the device in all of our hospitals, for example. And it has its challenges. For example, sometimes there is a screen problem. Sometimes there's also the geometry of the blade, because the device comes only with one size. It's not really suitable for all of the patient, and the device study mentions this. Can we say that what is the golden standard of using this device in some of in a very small sector of the cases? What I want to say is, use the manual blade, the basic method, for all of the patient, but it's going to be better to use the VL in a small sector of patients. 1, 2, 3, 4, 5. I did not read this in the study. The second thing is, how about, or did the study analyze the patient with a paradox that we continuously received in our emergency departments, which is the C-spine lesion? Is it advisable for using the VL in C-spine lesion? We are going to manipulate the patient's head because we need the line of sight when we insert the tube. I hope I could make myself clear. Thank you so much.
Okay. First of all, I fully agree that before we use, for example, video laryngoscopes, the main core our skills is manual laryngoscope, direct laryngoscope. And for example, from my perspective, I teach always at the beginning the students with the Macintosh or Miller laryngoscopes to obtain the skills perform the standard conventional laryngoscopy, and after then I add to the training some video laryngoscopes to help them, because normally, for example, in Poland, in each resuscitation table in the emergency department, in the operating room or in the anesthesia, we have some kind of laryngoscopes. The problematic thing is that we have different of those devices. For example, in my anesthesia department, we have McGrath and we have glide scope, and depending on which situation we're going for, I mean on the OR or on the laryngology, we put one or other device, so we should train all of them, and this is for me normally. But in normal situation, the problematic is that if we want to obtain the skills of airway management, we need to, according to the studies, perform about 20-30 intubation per year. But when we have in our background video laryngoscopes, those are much more easier because the learning curves, as you see, are much more lower. But when we should use it, I use it in each situation when I have the possibility of the difficult airway. I mean, even in the child without any trauma, in the older patients also. because it's helped us, but we should focus also on the main skills, I mean the direct laryngoscopy, because this is the first step how we should intubate. Because, for example, in the video laryngoscopes, everything is great, but the video laryngoscope can power off, so it will be then problematic for us. But, for example, when we're talking about the cervical spine injuries and the intubation of those, such as patients with the emergency department, I prefer at the beginning the McCoy, and if it's not working, then I'm thinking or asking other much more older anesthesiology staff to help me, and we're thinking how to do it. Of course, when we're starting the intubating, in the emergency medicine, we're working fast. In the anesthesiology, we have different thinking, because we can perform awake intubation and after then thinking one more time how to do it, peroxygenate one more time patient, and this is totally different. But for us, the most important thing is to intubate as much as possible on the first attempt.
Thank you, Dr. Darbe. In the keeping the respect of time, I think we have to move to the next speaker. As Dr. Ojanma gets ready, there's no introduction needed for Dr. Ojanma. He's one of the pioneers of point-of-care ultrasound in the world. His book on point-of-care ultrasound is famous. Just the Facts in Emergency Medicine is one of his other books, which every resident uses. Even I used it. And of course, Tintilani textbook is his championship contribution to emergency medicine. As we get ready, I want to re-emphasize the fact of the airway, which Dr. Zarbeck talked about, is that the basic skill set is needed, but AI-generated augmentation or support of airway management is very, very important, with the growing fact that the generation which is coming is more technologically savvy, more tech-friendly. I think AI will help them because of the number of residents have gone up, and the burnout and the number of hours of practice has gone down for them. So the amount of exposure of airways they have is much lesser than what we had during our training. So AI is a necessity for Gen Z, especially because they are in a changed surroundings. We did not have those settings. We were 2 shots out. You do twice and then you go for the cricothyroid. So here they need that technological support because of the lack of more training, because of the lesser training hours, so the lesser exposure. So I think AI always helps. So you have to think about it in a bigger sense. So over to Dr. John. I think the slides are up, so it's always our time. Thank you.
Lucas, that was the single best airway management presentation I've ever heard, so great job there. Good afternoon. I would like to begin by thanking Professor Dr. John Dash, Professor Dr. Gallwinker, EPACT, WASM, and the organizing committee for your kind invitation to speak here today. It is truly an honor, so thank you very much. The year is 2031. Picture these 2 internationally famous and, of course, very handsome emergency physicians 30 minutes before the start of their shift. In order for them to warm up their critical decision-making abilities and processes, they are running through a holographic simulation of an acute stroke patient. In another ED, an emergency physician uses augmented reality glasses for critical decision support during a trauma resuscitation. His AI assistant has already flagged his knowledge gaps from last week's cases and has formulated learning modules to help him improve his knowledge base. After his shift is over, He reviews the cardiac arrest case he just saw with 3 medical students. This is not science fiction. The scenarios that we are looking at here, at all 3 of these things, those foundations are being laid right now. And, in my opinion, we have reached an inflection point where the very way that we train our students and residents, and the very way that we maintain our clinical competency needs to undergo a significant transformation because the traditional method has been flawed for so long. So first of all, what do I perceive as a crisis in traditional residency training? Well, what are some of the current limitations? Right now, our emergency medicine residents are basically having to see patient after patient after patient, hoping that sheer volume alone will provide them with the necessary experience and expertise to become excellent practicing physicians. So right now, our emergency medicine residents hope to encounter enough pathology in order to build that pattern recognition. Case variability means that there's uneven training experiences between residents at the same program, and certainly between residents who are located in different geographic locations. And high acuity, low frequency conditions may never be encountered during their residency training. What are some other limitations? Well, traditional didactics really struggle to keep pace with rapidly evolving evidence. It's estimated that there are 5,000 papers being published every day, 5,000 daily in the medical literature. Some of those are good papers, some of those are not so good papers. But how can we expect residents and physicians to keep up with that sheer volume of literature? And the whole see one, do one, teach one model doesn't align with patient safety expectations. My second point is that there's a crisis in maintaining our clinical competency. In most places, there are no current standards for how practicing physicians need to demonstrate continued clinical competency. And in the few places that allegedly claim that they have a system in place, physicians report spending dozens of hours on written assessments that feel very disconnected from their daily practice. And as we all know, skills decay in areas that we don't use frequently. So how do practicing physicians keep up to date with all these latest advances, like airway management and other things? And how do practicing physicians demonstrate continued clinical mastery for board certification? We know that change is needed, but as a group, how can we architect the future of learning? Well, we certainly know that technology will play a huge role moving forward. Virtual and augmented reality are moving simulation well beyond what's currently possible with high-fidelity mannequins. Ultrasound-guided procedures with real haptic feedback can replicate true tissue resistance. We can now have simulations for managing mass casualty incidents, and there's going to be a presentation on that later in this Congress. Encountering rare presentations dozens of times before we actually see them will now be possible through simulation. So in the audience, how many times, or when was the last time that you had to do a breech delivery in the emergency department? Many of us have never even seen it, right? So now we can have a simulation where we review the delivery of a breech dozens and dozens of times before we actually see that case, knowing that the outcome for the infant and for the mother depends heavily on us having our A game ready when that rare presentation shows up. Similarly, the morbidly obese apneic patient who comes in and needs aggressive airway management, again, we can simulate that dozens of times before seeing that case in the ED. Artificial intelligence will be our learning partner moving forward. That's just something that we're just going to have to come to grips with and accept. A lot of people are resistant to AI, but we really need to believe that it will truly help us. There's going to be real-time clinical decision support that will adapt to each of our individual knowledge bases. And there's going to be individual tutoring systems that will help identify our knowledge gaps and help prepare us for the future. AI will also provide automated feedback for our documentation, diagnosis patterns, and resource utilization. It'll provide us with predictive analytics and on what refreshers we need in specific areas. So Dr. X may be excellent at endocrinology or weak at neurology, whereas Dr. Z may be the opposite. Instead of having the same learning modules for both, we can now predict which ones we need to individualize for those physicians. So the whole idea of AI is it's not going to replace clinical reasoning. As I always say, there is no substitute for sound clinical judgment. But AI is going to be augmenting our decision making in the future and helping us make intelligent decisions. And for resident education, just think, instead of having weekly conferences and monthly journal clubs, what if we had 5-minute evidence updates that were integrated into the workflow? How about if we had repetition algorithms to really ensure knowledge retention for our residents? And how about point of care learning that's triggered by the actual cases that they see? So the whole idea isn't reducing the rigor for residency training, it's about increasing the efficiency and the retention for our residents. One thing I would like to bring up that's controversial, and I would certainly love to hear, especially from the residents, about this idea, is my feeling is that the future should be competency-based and not time-based. I think that residents should advance when they demonstrate mastery, not after just simply a fixed time period, whether it's months or years. And also, I think we need to have continuous assessments throughout those ED-based observations. So, residents may be able to graduate from the residency, let's say a 4-year residency in 3 years and 3 months, but it works both ways. Someone who may be slower to adopt learning might have to stay 4 years and 6 months in order to demonstrate that clinical mastery. Controversial? I'd love to hear people's perspectives on that. So, longitudinal assessment programs are going to be key. We're going to have chart reviews by AI assistants that will review how well we are doing with our diagnostics. We're going to have AI review our procedure logs so that we can get real hardcore data on our outcomes and our complications, not just over a month, but throughout our careers. We're going to be able to receive 360-degree feedback from our colleagues, from our patients, and from our nursing staff. And finally, simulation performance will be tracked not just for that particular week's simulation, but throughout our entire careers, so that we can get data points on how well we're doing. Technology and AI are great, but what are some of the human elements that won't change? Really, we know that emergency medicine fundamentally is human work. The whole pattern recognition, that ability, that gestalt of seeing whether a patient is sick or not sick, still is developed through training and experience. Technology will never replace it. It might accelerate it, but we always need that human clinical judgment. AI will never replace mentorship. We will always need senior physicians who can help guide the next generation. And these senior leaders really will help us, the next generation, make value-aligned decisions, communicate with compassion under pressure, manage uncertainty, which is always there in emergency medicine, and maintain emotional resilience. We all know that emergency medicine is a team sport and not an individual event. So that technical mastery means nothing without the ability to lead teams, communicate clearly, and coordinate care during a busy emergency department shift. Social skills require practice in authentic environments, and AI will never replace these skills. So I guess the basis of my talk isn't whether we need to choose technology versus the traditional model, but how can we best integrate technology and the best parts of our traditional model. So let's look at a future where residents receive personalized curricula based on real-time competency data, and practicing physicians maintain expertise through brief, targeted interventions. Let's look at AI that can handle all the grunt work, retrieving data, and allowing clinicians to free up their cognitive resources for real clinical decision making. And let's look at a future where assessments are continuous and developmental rather than punitive. Let's imagine an ecosystem where simulation can provide intentional practice for those high acuity but low frequency events. So, what will the emergency department of 2036 look like? It's 2:14 a.m., it's a busy night shift, an AI triage system has already risk stratified your waiting room for you. Your smartwatch buzzes. You have a sepsis alert based off of the wearable device that a patient who is you're waiting in the parking lot who has just arrived at your ED. Your resident is using AR glasses during a thoracotomy, and meanwhile, you're supervising 3 nurse practitioners remotely who are working in emergency departments across the city. The skill set required to be an excellent emergency physician is fundamentally changing. The future of emergency medicine education and clinical mastery will depend on adaptive expertise, technology, resilience, and team leadership, not just memorized knowledge by reading a textbook. So which emergency physicians will thrive in the future? Those who embrace lifelong learning, those who see technology as augmentation rather than as a threat, and those who remain committed to the core mission of excellent patient care through continuous improvement. The future of emergency medicine will be defined not by tools that we create, but by the wisdom with which we deploy them. So let's build that future together. Thank you very much. I'd also like to do a quick shout out and thanks for our technical staff here. They've done such a great job in organizing all this and making this run seamlessly. So thank you very much.
Thank you very much, Dr. Young. I think we have time for two questions. And Dr. Hassan connect Zoom. Okay. And Dr. Hassan from Qatar is here now. Have you any question for Dr. John or Dr. Hassan? Question?
Yeah. Any questions for Dr. Ma and Dr. Althani, if you'll have any questions?
Dr. Bechet, you can ask question. Okay, Dr. Bechet.
Can we have a mic for Dr. Besset?
Gizem, gidiyor mu mikrofonumuz?
Mic,
Evet.
please.
Koşarak, hızlı. Buraya verelim, şuraya. Şuraya. Şuraya verelim. Çok geciktiniz. Şuraya verelim, evet.
Dr. John, thank you very much. Very much about this intelligence and important issue. This is our future, really our future. When you start to talk, I thought that you read my mind. Because in the morning, we discussed this issue with Dr. Sagat, you may remember it. So thank you very much again, you remind us about this important issue. Just, what do you think about the virtual reality in all training points of the emergency department? Thank you very much. Welcome again.
Thank you very much.
So, Dr. Ma.
Excellent point. I think it's critical that we incorporate all forms of technology, including VR. I think I can just think of so many cases. Airway management, for example, where VR would be wonderful, along with AR, along with AI, and all the other alphabet initials.
One of the key things which I would like to add to this is that today's generation, which we call the Gen Z, the Gen Z is a completely different mindset. It's the evolution of humans in a different race. And this Gen Z population understands, reads and perceives differently. They are more excited by handwork, skills. So you have to create the whole ecosystem of learning around skills, simulation, ultrasound. So AI will help, but in the end, the seniors, which is our generation who have been there, the millennials, will have to sit back and work with Gen Z to understand how they want to learn. They do want to learn, but they don't want to learn the way we are teaching them. Please understand this clearly, and that until countries realize that, it will be too late. So it is very important, as AI is, every day there is something new in AI. The generation which is governing emergency medicine has to understand what the generation which is going to practice emergency medicine wants to learn. And AI could be an augmenter. It does not replace the real sense of learning, but the style of education has to change. That is very clear. Thank you. You have a question?
Sorry, question? Büşra.
Hi again. Do you think that the technology will affect our mental health as physicians? And do you think that we will be resilient on this matter? Don't get me wrong, I don't think we are resilient right now. The burnout is in our daily routine. But do you really think that, how does the technology affect our mental health?
That is such an important question because wellness, as we know, is at the forefront of medicine right now. We know that burnout occurs. We know that physicians struggle with depression, with anxiety. It's just in the United States alone, it's estimated that 400 physicians commit suicide annually. And that's probably on a low number. I don't know about other places around the world, but I'm sure it's just as high because of that. Technology, I think, can cut both ways. Technology certainly could lead to burnout. You hear about social media, for example, creating a lot of issues for not only the younger generation, but for my generation as well. But at the same time, I think technology builds some hope in that we can use AI, for example, to help decrease some of the burdens. Documentation for me has always been something that has burnt me out. I used to spend 3 hours after a shift just documenting because I really was very, very, I guess, compulsive about wanting the next physician who saw that patient to know exactly what happened in the emergency department for their patient on a very detailed level. And that's good, but it was also just very burdensome for me. AI can now reduce that documentation from 3 hours to 30 minutes, freeing up a physician's ability to get home sooner, to be able to spend more time with their family rather than being, in the hospital having to document. So I think that's just one example how technology might be able to help with our mental health in the future. So I have a lot of hope for that.
That was an excellent point, Dr. Moran.
So John, one of the things that we know about AI, the platforms are made by people, right? It's programmed initially by people, and a lot of the biases that exist in our societies are being replicated in AI, specifically around ethnic, racial, and gender, as well as age issues. And so I've heard a lot of concerns from people that as AI guides our decision-making, who should be resuscitated, how aggressively they should be resuscitated, that some of this bias is going to come out in terms of deciding whose life is worth saving and who is deserving of more expensive treatments. How do you think that we can program AI or respond to AI or work with AI to take some of these biases out? Because as physicians, our Hippocratic oath is that we are supposed to put the patient first.
You're absolutely correct. AI is, as they say, great stuff in, great stuff out, garbage in, garbage out, bias in, bias out. And there's no way of getting around that component. Ultimately, as I mentioned in my talk, there's still no substitute for sound clinical judgment. This is still a human endeavor. Emergency medicine will never be replaced by AI. And so we still need senior physicians teaching the next generation about various biases and how we can overcome those biases to make those sound clinical decisions that are truly in the best interest of our patients.
All right. Do we have Dr. Althani still online? Or did we lose him? Is Dr. Althani? Yes.
Yeah.
Hello, sir.
Yes, I am online.
Good evening, Dr. Althani. We are missing you. We are missing your presence here. So I have your lecture was fantastic as usual. People should know that the Center of Excellence in terms of trauma interventions is HMC Qatar. So if you have time, you should visit it. I call it the Disneyland or Hollywood studio of trauma. And you should visit the Trauma Disneyland, which is HMC Qatar, which is created by Dr. Althani, who is like a Steven Spielberg of HMC. So one of the things I want to ask him is, you all are good at RIBOA, you all are good at ECMO. So what is your first success of RIBOA and ECMO, and what's your experience with that? And secondly, what is your system for portable ECMO? So ECMO which can move around the hospital. And the third, do you incorporate simulation and sonography in ECMO and RIBOA training? Thank you.
Thank you. First of all, I would like to thank the organizing committee really for their kind invitation and all the effort that's been made to make this happen, especially Professor Bashar and his team. I would like also to thank you, Sagar. I miss the meeting really, but the current situation, and we go with the wave, So one day we have a green light to move, and the other day we have no green light to move. Really I miss the gathering, which is something that we always look forward to be part of. Regarding the BOA, we have actually protocols, guidelines, and pathways for BOA at Hamad. We have also simulation, so all the trauma residents rotating with us go through a simulation training course for the BOA. The activation protocol also there for the RBOA, so when we activate the RBOA, as usually we involve not the trauma only, but the interventional radiologist, the hybrid OR nurse, the anesthesia team for the trauma, and that can move to the trauma recess or move to the hybrid OR. But we initiate usually RBOA in the trauma recess if it's needed for the patient, and we move them to the hybrid OR. Regarding the ECMO program is a national program. And there is also a local simulation training program which was established with Qatar University, and the ECMO program led by Professor Ibrahim Fawzi. The program is really now quite successful. We have what we call the SHARP team for inter-facility transportation, regional transportation, and also they have the transatlantic transportation for ECMO patients. So we actually responsible for transporting ECMO patient from the GCC country, and also transatlantic for patients who require treatment abroad, whether it is in United States or even in Europe. So the program has been active from 2014, and this is well established. So that's regarding the RBOA and the ECMO program. We have a well-established also relationship and teamwork, which include the RBOA team, the trauma team, and also the cardiology team. So we work together in order to facilitate for the patient who require, whether it is ECMO, interventional radiology, or trauma surgery in the same setting. I think in one of my cases that I put in the presentation, we illustrated actually how we did this for a patient on the extreme, superior mesenteric artery injury, vein, transected thoracic aorta, and post-operatively developed ARDS from aspiration, requiring ECMO after conventional ventilation failed for correcting the issues, and the patient did it quite well. So this requires a team to work together in order to establish this. But of course, we are not the creator of such system. We adopt system from around the world. We learn from Turkey when we visit. We learn from people from United States, from you, Dr. Sagar, and the rest of the world. So I think this is a network of activity to reach a level that everyone desires to reach for their patient care. Thank you.
Dr. Hassan, always.
Thank you.
Thank you very much.
We all need to congratulate Dr. Al-Thani. His work of 20 years this next year, Qatar Trauma Centers completes 20 years of service of trauma, which includes big achievements like the FIFA World Cup and many such things. So congratulations to his hard work. He deserves a round of applause, please, everybody, as 20 years of Qatar Trauma Center will be celebrated at this Congress this year. Thank you.
Thank you, everyone. Thank you for the kind presentation.
We'll finish this first section and we will start the opening ceremony. We have a time, only 10 minutes. 10 dakika arkadaşlar mola, verelim mi 10 dakika? 10 dakika mola, açılıştayız. Hepimiz fantastik bir açılık sizi bekliyor.
Mustafa Kemal Atatürk and his heroic comrades who sacrificed their lives in this country. Following the moment of silence, we will proceed with the national anthem. Significance of the day. It is a special meaning for us that our Congress coincides with National Sovereignty and Children's Day, April 23rd, the only children's holiday in the world. This special day dedicated to children by Mustafa Kemal Atatürk symbolizes hope, peace, and the future. The opening ceremony will begin with the videos we have prepared for our speakers. Thank you for your presence, Dr. Mihail, Dr. Lucas.
Mi sono alzato, oh bella ciao, ciao, ciao, ciao, una mattina mi sono alzato e ho trovato l'invasore, un partigiano, dammi via, oh bella ciao, ciao, ciao, ciao, partigiano, portami via, che mi sento di morire. E se io muoio da partigiano, oh bella ciao, ciao, ciao, ciao, se io muoio da partigiano.
Tidak berkias jalinya rentang beribu pakailah mana hendak berhias ceminggu deras seribu mendendam unggas biar diputar jalan yang tinggal jangan berliku di lampu emas jadangnya indah bertanda lengan hidupku hias cempaka kenangan tepian makanya ku
I would like to invite Albi Abdulrahman to the stage for his speech.
Good evening, ladies and gentlemen. I'd like to first thank the organizer, Professor Basa, and the whole of team of IPA for inviting us. With me, I am an emergency physician from Kuala Lumpur Hospital, Selayang Hospital. Can we have a round of applause for two of our gentlemen there at the back? One of them is still a bachelor, not married yet. Dr. Jamal and Dr. Nabil, can you just stand up, please? And I think it was a pleasure and an honor to be at this conference. And it's full of elegant, full of colorful, and the more important is the hospitality as well as the friendship that we created along the journey of this conference. Thank you very much. Thank you, Professor Baza and all of the team for inviting Malaysia. Thank you.
Thank you, Dr. Albi.
Of ik zin heb in een sigaret. Het is 2 uur 's nachts. We liggen op bed in een hotel in een stad waar niemand ons hoort, waar niemand ons kent.
Thank you, İCEM. Thank you, Basa, and everybody who organized this. It's always a treat to come to Turkey and taste your hospitality and also the friendship. I mean, we all are here to learn from each other, inspire each other, and try to make our young people better doctors. And once again, thank you again for your hospitality, and we look forward to seeing you all next year in November in Wasem, Amsterdam. All of you are welcome.
Thank you for your kind words.
خيبت توقعاتك دمرت خلاص حياتك بتراجع في حساباتك طيب راجع كل اللي فات الحلو في ذكرياتك قعدت انجازاتك مشاركك فيها انا من طريقك ياللي صعب تمشي في الطريق انا كنت كل امل حياتك وانت بتموت بالبطيء انا جزعت في ثانية بعد
I would like to invite Halit Ataya to the stage for his speech. Abdul Hadi Kaşkandi, please come to space.
Thank you very much. On behalf of our team in Saudi Arabia, I would like to thank the organizing committee, special thanks to Prof. Bashar, Dr. Bajat, and everyone who invited us here. It's a long friendship and collaboration with Prof for the past 15 years since our first conference in Medina. So it is always, we are happy for the hospitality, for joining here. And I think most important is the networking, because we see, I think it's the first of kind of conference that we reach everyone from around the world. Literally, this is the exact conference where we meet and network with everyone. Thanks a lot, and hopefully to learn a lot from each and every one of you. Thank you.
مفيش حاجة تيجي كده انت حبيبي كده وارجع زي زمان يا ابني اسمعني هتدلعني تاخد عيني كمان مفيش حاجة تيجي كده انت حبيبي كده وارجع زي زمان يا ابني اسمعني هتدلعني تاخد عيني كمان حبيبي قرب بص وبص بص عم ازعل ازعل بص بص احسن حبعد ابعد قوي نصلك تبقى انت اكيد خسران حبيبي قرب بص وبص بص عم ازعل ازعل بص
I would like to invite Amin Antoine Kazi to the stage for his speech.
What can I say more than thank you for inviting us and making this event happen year after year, bringing people together. I can also say that I am very proud of Turkish emergency medicine. What EPAT has done in Turkey and actually in the world is very special. Congratulations and thank you for being here with you. I do hope to see you next time we do the Mediterranean Emergency Medicine Congress, which most likely will be in Istanbul in 2027. Looking forward to it.
I would like to invite Dr. Roger Dickens to the stage for his speech.
Merhaba Türkiye. Afrika'nın güney ucunda selamlar. And that's where it stops. It's an absolute pleasure to be back in Antalya with my friends from EPAT, especially considering we are celebrating your 27th year this year. I think it is absolutely fantastic. Now, a couple of years ago, Paul Kivela stood on this stage and tried to convince Bashar that he should take up American football. And I needed to prove a point that as the world rugby champions at present, I'm going to try and convince him to start playing rugby. And with that, I'd like to present him with the South African rugby ball, but also the rugby captain's jersey.
Professor Bashar, please come stage.
Teşekkür ederiz.
Thank you for your kind words, Dr. Roger. You're so welcomed. I would like to invite Oscar John Ma to the stage for his speech.
It is always such an honor and a privilege to be here amongst friends and colleagues. All of you are just a great inspiration with the way that you conduct research and pump out your studies, the way that you teach the next generation of emergency medicine physicians, and the way that you practice clinical emergency medicine, all in the name of providing our patients with the best care possible. So thank you very much and enjoy the Congress.
İzini bilirsin, sen bilirsin, sen
With your biggest applause, I would like to invite President of İPET, Professor Başar Cander.
Okay. Arkadaşlar, burada olduğunuz için çok mutluyum ama şu ilk videoyu unutmadınız değil mi? Şu boynunuzu vurun. Neyse, size bir video hazırlamıştım ama bu kadar geleceğinizi tahmin etmiyordum diye Prens'in bir videosu vardı. Onun gibi bu kadar geleceğinizi tahmin etmiyordum. Gerçekten çok gurur verici bir kalabalık karşısında hitap etmekten çok mutluyum. Şimdi yabancı konuşmacılarımız için kulaklık dağıtacağız. Çünkü çok farklı şeyler anlatıyorum. Onları İngilizce anlatmam mümkün değil yani. Biraz zor olur. Onun için kulaklıklar gelecek. Hızlı bir şekilde gelirse zaten ilk şeyler pek kulaklıkla ilgili değil arkadaşlar. Kongremizin birçok bileşeni var. Başarının birçok bileşeni var. Ama hiç unutmamak lazım ki biz ne yaparsak yapalım, kongrenin başarısında en büyük pay burada katılan sizlerindir. Hepinizi ayakta alkışlıyoruz. Şimdi arkadaşlar biraz değiştirelim. Geçen yıldan bu yıla biz neler yaptık? Geçen yılki kongremiz nasıl geçti? Sesi açabilir misiniz arkadaşlar?
Ektim çöllere de biçtirmedim ellere. Ektim çöllere de biçtirmedim ellere. 15'inde yar sevdim de sezdirmedim ellere. 15'inde yar sevdim de sezdirmedim ellere. Çıt çıt çıt çıt çenene de sar beni be.
Arkadaşlar geçen yılki kongremiz çok coşkuluydu. Ama biz bir kongre yapmadık bir yıl boyunca. 4 tane, 3'ü uluslararası olmak üzere 4 tane kongre yaptık. Atüdel olarak 4 tane uluslararası kongre katkılarımız dışında biri ulusal, 3'ü uluslararası olmak üzere. Onun için onlardan da biraz bahsetmekte fayda var. Bunlar otomatik çalışacak mı Samet? Bizim de Aziz Yıldırım gibi bir Samet'imiz var. Doğru mu Samet? Otomatik çalışacak mı bu? Hadi başlat. Tamam. Evet arkadaşlar Konya'daydık. Konya'yı bir hatırlayalım. Konya'da çok güzel bir travma kongresini başarıyla gerçekleştirdi arkadaşlar. Konya ekibine buradan şükranlarımızı arz ederek alkışlarınızı rica ediyorum. Evet. Sonra Erzurum'a gittik. Erzurum'da da büyük bir kongre yaptık. Nihat ve Batuhan buradalar mı? Evet, çok teşekkürler. Gençleşiyoruz değil mi? Arkadaşlarımızı alkışlayalım. Arkadaşlar Macaristan'a gittik beraberce. Macaristan, Budapeşte'deydik. Sonra Kıbrıs'ta yine uluslararası bir kongre yaptık. Ve bu kongremize hazırlanmaya başladık. Bu kongremize başka stillerle hazırlandık.
Doktor olarak 2 gündür karnım çok ağrıyor.
Geçmiş olsun. Karın ağrısı şikayetiniz var mı? Herhangi bir kronik rahatsızlığınız var mı? Herhangi bir ameliyat öykünüz var mı?
Hayır, bir ameliyat öyküm yok.
Herhangi bir ilaca veya yiyeceğe karşı bir alerjiniz var mı?
Hayır,
En son Akudar Kongresi'ne ne zaman gittiniz?
çok oldu.
var mı?
Hayır.
Hastanız ameliyathan yok.
Tabii böyle değişik kurgular yaptık arkadaşlar.
Efendim?
Kolay gelsin. Bir hastam var sana danışacağım.
Şikayeti var.
29 yaşında erkek hasta. Göğüs ağrısı, çarpıntı şikayeti var. Bir de kongre kaydını yaptırmamış.
Hemen anjiyo yazın.
Şimdi tabii biz bunu kurgu olarak yaparken
Ömer, eğer kazanırsan Atuder Kongresi'ne katılacaksın.
Atuder Kongresi?
Evet.
Hastanın röntgen görüntüleri... Öncelikle geçmiş olsun. Nasıl oldu anlatabilir misin?
bizi ayarlayalım.
Normal nöbetteydim. Sakin bir akşamdı. Bir gün hocam geldi. Seni Atuder Kongresi'ne yazdık dedi. Önce inanamadım. Sonra vücudum sıcaklık bastı. Kalp hızım yükseldi. Dedim bu neyin taşikardisi? Şikayetlerin o zaman başladı yani. Tabii o an başladı. Hani ben mutlulukla yükselirken estere yükselmiş. Tam ne oldu? Klasik Atuder Kongresi kaynaklı mutluluk enfarktüsü.
Buradan hocalarımıza sesleniyorum. Lütfen Atuder Kongresi gibi büyük bir organizasyona gidebileceklerini asistanlarımıza ani bir şekilde söylemeyelim. Dozunda heyecan, sağlıklı asistandır. Atölye acil, ilk kongrelerdir.
Şimdi biz geçmiş olsun şikayetlerini söylüyoruz. Bu gerçek bir öykü. Yani adam kalp krizi geçirdi. Gerçek bu. Biz kurgu yaparken Erzurum gerçeği yaptı bizimki. Biz kurgu yapıyorduk, Erzurum'da gerçeği oldu. Yani demek ki böyle bir şey de var. Kalbin sempatik sinirinin ismi. Bunu tercüme etmeye çalışsınlar. Bravo, bravo ama çok yanlış gibisiniz. Neyse, tebrik ederim. Tebrik ederim, evet. Şimdi arkadaşlar, ya onu innerve ediyoruz, ya onu simüle ediyoruz. Onu ne yapıyoruz? Mesela dopamin veriyoruz, teofilin veriyoruz mesela, kronotropik. İşte bir de arkadaşlar, bunun daha ileri şekli var. Penge, QRS arasındaki ilişkinin tamamen koptu. Yani ne oluyor? Buradaki gördüğünüz EKG'deki bakın şuradaki EKG'de QRS'ler tamamen kendi aralarında düzenliyse P'ler tamamen düzenli. QRS'ler de düzenli. Biz buna 3. derece blok diyoruz. Yani blok 3.
Hocam kusura bakmayın ama blok 3 kongreye de geliyor.
Bir sanatçıyı aramızda göreceğiz. Öyle böyle değil yani. Konserlerinden bir tanesine bakın. Atüder'den başka hiçbir yere gitmiyor. Sadece Atüder'e geldi. Ve böyle bir sanatçı ancak Atüder getirebilir. Unutmayın. Tabii burada yine genç öğrencilerimize sizin nezdinizde mahsusta da teşekkürlerimizi iletiyoruz. Tabii futbol turnuvasına da hazırız arkadaşlar. Tek bizden geldi tabii. Biz biraz yaşlı ama olsun. Sonuçta biz de varız. Evet yani Atuder Kongresi hayatımızın bir parçası olmaya devam ediyor. Ama arkadaşlar biz sadece kongre yapmıyoruz. Yıl boyunca başka neler yapıyoruz? Mesela kurslar yapıyoruz. İKYD kursları. İleri kardiyak yaşam desteği kursları. Tabii bunlar aktivite hale de geldi arkadaşlar. Niye bu kadar bu kursları veriyoruz? Niye bu kadar önem veriyoruz?
Thank you.
Bırakıp gitmek yok tabii. Çok iyi olmak zorundayız bu kurslarda.
Okay. We want nice, steady compressions. What? Look at Trap. That's CPR that'll save a life.
Oh, thanks. I used to be a lifeguard.
What did you do? I don't know. You were too good at CPR.
Bu kadar iyi olmasak da yine reba kurslarımız arkadaşlar. Burada da verdiğim çok önemli bizim için. Uluslararası düzeyde veriyoruz bu kursları. Reba kurs ekibimize bir alkış verdim. Ve kritik bakım kurslarımız. Yani yıl boyunca yaptığımız aktivasyonlar, Türkiye'nin her yerinde diyelim, bazen dışarıda birlikte kritik bakım kursları vesaire böyle devam etti arkadaşlar. Manisa'da yaptık, Konya'da yaptık, Niğde'de yaptık. Türkiye'nin her yerinde kurslarımız bu şekilde devam etti. Bunlar da ultrason kurslarımız arkadaşlar, Ultimate. Ultrason da artık acilin çok önemli bir parçası olmaya devam ediyor arkadaşlar. Birçok yerde yaptık. Tacikistan dahil. Pardon, bunu oynatalım. Gaziantep'te. Samsun'da. Kırşehir'de. Yani ulaşabildiğimiz her yere ultrason ekibi ulaştı. Onlara da bir alkış rica ediyoruz Bora Bey ve ekibine. Tabii biz bu arada boş durmadık. Bir de kitaplar yazdık ekip olarak. Geçen baktım 40'a yakın kitap olmuş arkadaşlar. Yazdığımız kitaplar. Bu konuda özellikle şimdi daha önemli bir aşamadayız. Uluslararası kitap bölümleri yazmaya başladık. Orada da arkadaşlar Rose'un çevirisini görüyorsunuz. Şimdi critical care, nörolojik emergency. Bunların hepsinde Lucas'la beraberiz. Lucas'ı da buradan alkışlayalım. Evet. Devam ediyoruz arkadaşlar. 4 tane dergimiz var. Bu dergiyle ilgili haberimiz de şu arkadaşlar. Siz doçentliğe rahat başvurun diye kabul aldığınız anda sayfa ve doyu veriyoruz. Dolayısıyla sizin kabul aldığınız anda doçentliğe başvurma şansınız oluyor. Bir diğer gelişme arkadaşlar, Acil TV'de haberler kısmı başladı.
Bir araya getirecek International Continental Emergency Medicine 2026, 23-26 Nisan 2026 tarihlerinde
Bu şu anda
Royal
sadece
düzenlenecek. Kongre aynı çatı altında
haftada bir
şekilde 23. Ulusal Acil Tıp Kongresi, 13. Kıtalararası Acil Tıp Kongresi ve 13. Uluslararası Kritik Bakım ve Acil Tıp Kongresi ile sağlık camiasının önemli buluşmalarından biri olmaya hazırlanıyor. Organizasyonun resmi internet sitesinde yer alan bilgilere göre kongrenin resmi dili İngilizce olacak. Etkinlik programında bilimsel oturumlar, kurslar, alanında uzman konuşmacıların sunumları ve sektörel katılımların öne çıkması bekleniyor. Kongrenin acil tıp uygulamalarındaki güncel gelişmelerin paylaşılması, farklı ülkelerden uzmanların deneyimlerini aktarması ve disiplinler arası işbirliklerinin güçlendirilmesi açısından
tabii acil televizyonu açmak kolay değil.
NTV Mobil Haber izlediniz. İyi günler. Ne ya?
Ruhsatlara iptal edilen 138 bin millet için acayip inşaatı 30 bin.
Yani canlı yayın yapacağız ama böyle kaçak.
Silivri Belediye Başkanı Muhsin Yavuz, ilçenin sosyal ve ekonomik anlamda kalkınmasını sağlamak üzere bazı projeler geliştirmeyi düşündüğünüz.
Efendim çekilişimize başlamadan bildiğiniz gibi her hafta stüdyomuzda hazır bulunan Milli Piyango İdaresi yetkilimiz ve noterimiz için sizlerden büyük bir alkış rica ediyorum. Efendim kendilerine hoş geldiniz demek istiyorum. Hoş geldiniz.
Maalesef canlı yayınlar beni.
Türkiye'de en fazla panda
İstanbul'da yaşıyor desek şaşırmaz mısınız? Ama öyle etiyle, sütüyle, kaymağıyla İstanbul mandası şimdi canlı yayında, ekranda efendim. Yok o Erkan, sevgili Erkan, manda yanında olacak değil mi Erkan? Yanlış bilmiyorum.
Evet. Neyse burada keselim. Sonuç olarak arkadaşlar bu kadar iş yaptık ama hala 200 milyon hasta geliyor bize. Geçen haberleri yaptık. 200 milyon bir yılda hasta geliyor. Tabii bu hastalar bir şekilde acili seviyorlar, geliyorlar. Bizimle de uğraşıyorlar böyle.
Aşıyla ne alakası var? Tırnak mantarı mı ya?
İşte aşıdan önce yoktu. Aşıyı yaptı, sapsarı aşağıdan yukarıya doğru oldu.
Dayıcığım aşıyla alakası yok mu? Nemli kalmış ayaklarım, ondan oluyor.
Aşıdan oldu, aşıdan oldu. Bak bizim İhsan da hanımıyla kavga etti mesela geçen gün.
Niye?
Aşıdan.
Ne alakası var?
Ay gelsin, bir magnezyum yazdıracaktım da ben.
Ne şikayetin var?
Şikayetim yok da Instagram'da bir doktor tavsiye ediyordum.
Şikayetin yoksa niye magnezyum yazayım ben sana?
Hocam ama gaz spazmına, kolesterolü falan iyi geliyormuş.
Gaz spazmın var mı senin?
Yok.
Kolesterolün var mı?
Yok.
Tamam, motor yağmalıyorsun. İyi eksikse yazdırırsın bunu.
Yani çevirmeye yakalanmış, ceza yemiş.
Alkol yok bende. Bunda da bir kaşıntı var. Dilim de sürekli uyuşuyor. Gözlerim kaşınıyor. Ciğerlerimde de bir hırıltı var. Esanede de bir sorun var. Ereksiyon problemi yaşıyorum.
Ya, araç muayene istasyonu mu lan burası? Acil bir şey var mı?
Ereksiyon problemi acil. Hocam kolay gelsin. Ben bir serum alabilir miyim?
Oğlum ketçap mayonezli sıkmayayım.
Hocam merhaba. 3 gün önce babamı getirmiştim de damar yolu açarken kolunu kanatmıştım. Müsaade varsa bir tur dövecektim size.
Ha, 3 gün önce Necati Bey'in için.
O yurt dışına göç etmiş sanırım ya. Biz de elimizde kalanlarla artık idare edeceğiz.
2 tanesi de hasta.
Bir de şiddet olayları var tabii. Bu yoğunlukların sonucunda karşımıza böyle şeyler getiriyor arkadaşlar.
Bağdaş kuruyorum. Karıncalanma oluyor. O yüzden geldim.
Bağdaş kurarken kanıcalama oluyor. Normal değil mi?
Ben yine geldim bir göstereyim. Yaşlılık işte biliyorsun.
Yaşlı oğlum ben neden oluyorum bağdaş kurarken?
Ama arkadaşlar da burada onları da görmeye geldim ben.
Ha ortam.
Aynen öyle.
İyi bari. Ortam önemli ya.
Çok.
Boş ver.
Evet.
Muhabbet burada demek ki mahalleden arkadaşlar.
Mahalleden hepsi.
Tabii böyle arkadaşlar acil servislerde.
Hocam damar yolları hazır. Tamam bir daha. Ya atmet yolu bana veriyor burada. Çıksana lan dışarı. Zaten hasta almıyorsun. Oyalanıyorsun bir kere. Oğlum ne diyorsun sen? Çıkarsın oğlum dışarı. Hastaya böyle davranamazsın. Kime şikayet edeceğim? Siktir git nereye şikayet edilse git çık lan dışarı. Var ya. Oğlum polis var ne ya?
Alo.
Next please.
Tabii böyle bir durumda bunları da ifade etmek kolay olmuyor.
Well,
Это замечательная больница.
This is nice hospital.
it's not. What's your emergency?
Обращайтесь, пожалуйста, в телефон.
Please talk to phone.
What is your emergency?
Какая у вас чрезвычайная ситуация?
Спасибо за вопрос, Вэл. У меня нож в спине.
Thank you for asking. Val, I have knife in back.
I got a level 1 stab wound in the hernia and an IV. You're gonna be okay, sir. Go with
Ой,
us.
спасибо за помощь с ножом, Вэл.
Bir de böyle hastalarımız var tabii. Bazen de fazla müdahale ettiğimizde oluyor.
Geldik. Doktor bey. Geldik. Hadi hemen müdahale et. Endişelenmeyin. Tansiyonu sakin. Biraz sakin.
Nasıl oldu bu? Birkaç gün önce ben biraz öksürüyordum. Hastaydım galiba. Benden bulaştı herhalde.
Aman hiç dikkat etmeyin zaten.
Ay bu aletler falan alt tarafı grip oldu.
Hanımefendi siz idrak edemediniz galiba durumu. Sıradan bir grip değil bu. Erkek gribi. Anlamaz doktor bey, anlamıyor. Sakin ol, sakin ol. Kıpırdamıyorsunuz. Ne olursa olsun 3 gün boyunca koltuktan kalkmıyorsunuz. Beyefendi ne zaman bunu çalarsa yanına giriyorsunuz. Şefkatli bir şekilde kafasına. Nerede?
Do you know why I pulled you over?
Why?
Your wife fell out of the car about a mile back.
That's why she was so quiet.
Tabii acilde bir de böyle şeylerle uğraşmak zorunda kalıyoruz tabii.
Bir dahaki sene yolcuda gel. Geçmem yolcuda gel.
Tabii acil tıp uzmanlığı böyle şeylerle uğraşmak zorundayız.
Help, we need a doctor in here.
I'm a doctor.
No, we need a real doctor.
Dermatologists are real doctors.
Okay, fine.
CPR yerine botoks yapar mı?
Okay, no more wrinkles. His Botox is going to look great.
Blood you seek? Welcome to join us. But you bring only this handful of soldiers against Xerxes? You see, I was wrong to expect Sparta's commitment to at least match our own. Doesn't it? You, there, is your profession. I'm a partner. And you, Arcadian, what is your profession? Sculptor, sir. You, blacksmith. Spartans! What is your profession?
Biraz da böyle işte. Türkiye'deki doktor manzaraları da biraz yani değişik olabiliyor. Ama konsultanları da anlamamız lazım.
Bir gecede ya. Mevlüt ya. Tamam ne yazıyorsun ya? Müdür Mevlüt ya. Ona ben... Şuna bak Ertem ya. Türkiye'ye ne var? Telefonu döneceğim ya. Sen
Konsultanları anlamamız lazım. Bazen de hastaları da anlamak lazım tabii.
I went to the doctor and I was petrified. He said I gotta change my diet because my sugar's too high. He told me no more pasta bread and no more sweets and no more wine. But this guy must be out of his mind. I said, Doc, I love sweets. That's why I give myself an insulin to control my diabetes. Now you telling me no more pasta and wine, no more sweets and no more bread. Why don't you just grab a shotgun and put it to my head? I say stop, I can't take it no more. You tell me one more time what I can't eat, I'm gonna pass out on the floor.
Bir de hastaları anlamamız lazım. Doktorluk önemli tabii arkadaşlar ama bunun böyle bir yan etkileri de oluyor tabii. Sağlık çalışanlarının. Yıllar geçince biz de yıpranıyoruz.
Ben doktorum.
Bir hasta yok ki kardeşim.
Ben kalabalığı görünce kusura bakmayın. Ama doktorum yani, boru değil, alt yalıklığım yani.
Arkadaşlar ben çok kötüyüm ya.
Açılın ben spikerim.
Spiker ne alaka? Alerji.
Alerjidir olduğunuz alerji.
Boğazlarım.
Boğaz, tek bir boğazım var. Boğazım diyeceksin. Boğazlarım yanlış mı var? Hayır ben doktor.
Onlar var tabii. Evet dedik ya bu kadar nöbetten sonra doktor bana bile böyle olur. Biz de böyle oluruz. Beraberce döndürüyordu.
Olmuş.
Tabii bizim böyle bir başkanlık şeyimiz devam ediyor yıllar geçtikçe ama bu şeyi Fenerbahçe kısmına gelmeden kongre olmuyor. Ne kadar diyor ki ya Fenerbahçe kazansın öyle gideyim kongreye. Ama maalesef böyle bir şansımız şu ana kadar olmuyor. Ve hep diyorlar iki seçenek var. Ya bir Galatasaray sihir yaptı. Bu maçlar böyle bir. Ya da Aziz Yıldırım'ın ahı tutuyor. O yüzden bu şeylere dikkat etmemiz lazım.
Fenerbahçe'nin kendisiyim. 30 yılımı bu kulübe verdim ben.
Öyle mi? Ben hapise gittim ya.
Helal olan bir tane. Bir tane. Onların hepsini toplayınca bir tane yap. Hepsini toplayınca bir tane yap. Seninki daha güzel bak.
Şimdi bu andayız maalesef. Fenerbahçeliler olarak beyefendi.
Hangi takımlısın?
Onu konuşamıyorum ben, yasak.
Neden?
Doktor yasakladı, stres yapıyor bende.
Nereden baksan karşımızda bir stres faktörü var. Yıllar geçiyor, değişmiyor ama.
Bir erkek neden hoşlanır?
Bir de Fener'e vurmayalım o kadar. Evet arkadaşlar, kısaca Fenerbahçe'den değindikten sonra şimdi gelelim ödüllerimize. Şimdi biz yıllarca ödüller aldık, ödüller verdik. Bu yılda ödül vereceğiz tabii ki. Altın Acil ödülleri, Gizem nerede? Gizem gel. Altın Acil ödülleri, Gazi Yaşargil'e gitti, Aziz Sancar'a gitti, Goldfrank'a gitti, Kival'a gitti, Bingür Sönmez'e, Linsen'de, Kazli, Conma, en sonunu Fatıma Latife'ye verdik 2025. Şimdi 2026 ödülü için kimi çağırıyoruz?
She is a professor of emergency medicine at the University of South Alabama and the president of the American College Academic International Medicine. We are incredibly proud of to host such a distinguished figure at our Congress. Please give a warm round of applause for Professor Dr. Lisa Moreno Walton.
Thank you. This is a complete surprise and an unbelievable honor to receive the gold medal from EPAD. I'm actually almost near tears. I am so thrilled to receive this honor, and I'm so thrilled to be back here in Turkey. I have come here maybe 15 times, and it's one of the most wonderful countries in the world. I appreciate your friendship. I appreciate all that I learned from you, and I hear so much of people who are coming to the stage talking about friendship. I think I speak for many when I say that I am a much better doctor and I am a much better person because of the love and the friendship that I share with so many people from so many cultures and faiths and backgrounds and lived experiences that just enrich my life and make me better at serving my patients and just being a better human being. Thank you so much for all that you give to my life. I love you all. Thank you.
Şimdi devam edelim. Evet, ödüllerden sonra İtalya'yı bahsettik arkadaşlar. Gelecek kongrede kare kodları okutun. Etiyopya var önümüzde, Hollanda var. Oraya göndereceğiz. Şey yapıp, kura çekip yollayacağız arkadaşlar. Bunu da dikkat edin. Etiyopya'ya da davet ediyoruz sizi. Böyle bir üç adam arıyoruz ki.
Bir tanesi.
Dün gece 2'de bitirdik ekibi kutluyorum. Bu çalışmasından dolayı gece 2'de bitirebildik çalışmayı. Onlara da bir alkış rica ediyorum. yani sunumu burada bitirdim ama şimdi konuşmam bitmedi arkadaşlar. Atatürk bir baba ocağı hepimiz için. Dolayısıyla büyümeye devam edeceğiz. Herkesi kucaklamaya devam edeceğiz. Bu konuda gerçekten her yıl üstüne katarak gittik kongrenin. O yüzden bu kongrede çok emeği geçen insanlar var. Galayı hepinizi bekliyoruz. Ama şuradan başlayacağız. Öncelikle TİKA her zaman yanımızda. TİKA Ali Fuat Cebeci burada mı? Ali Fuat Cebeci. Hocam sizi buraya alalım. TİKA'ya teşekkür plaketimizi sunalım. Alkışlarınızla. Bunun arkasında şey var mıydı ya? Sponsor firmaların görüntüsü var mıydı benim arkamda? Onu da alalım. Şimdi biz bazı konuşmamda ben bu resimleri yetiştiremedim. Bütün yönetim kurulundaki arkadaşlarımız burada. Ondan sonra konuşmacılarımız burada arkadaşlar. Ve ana sponsorlarımız burada. Hepsine çok teşekkür ediyorum. Ama biri bizim için çok daha farklı bir yerde oldu. Her yıl olduğu gibi Neotek. Burada kim burada Neotek'i temsilen bulunuyor arkadaşlar? Evet hemen alalım alkışlarımızla. Hocam, Mehmet Hocam buraya gelebilir misiniz? Bir de diğer ödüllere geçelim. Mehmet Hocam'ı da alayım. Şimdi bu hocalarımız en son da onlara hediyelerini takdim edeceğim ama onlara en son, onlar yanında dursunlar. Şimdi arkadaşlar öncelikle kongremizin başkanlarını söyleyelim. Evet, Gizem. Efendim? Evet, hatırlatıyorum. Onu en sonunda verecektik ama şimdi verelim. Şimdi biz şeylerden başlayalım. Kongre. Evet. Kongredeki başkanlarımızdan başlayalım. Evet, kim var? Evet, olur.
Tamam. 13. Kıtalararası Acil Tıp Kongremizin eş başkanlarından Doktor Sagar Galvankar'ı ödülünü almak üzere sahneye davet etmek istiyorum.
And thank you everyone. This is a very big leadership issue in the world that Turkey has championed the cause of the World Academic Council of Emergency Medicine. We are one team. Every year at Antalya in April, the World Council meets, the leadership meets, and the annual Congress is always at the end of the year. So twice a year, thanks to EPAT and their leadership, in the center of the world, the World Academic Council meets in summer at Antalya, and then in Ethiopia we'll meet next year. Again we'll meet in Antalya, and then we'll meet in Amsterdam. These are very, very important things for academic medicine, and I'm very thankful to the EPAT team because we have been able to do a lot of good work because of that, which I think everybody should value when it comes to the creativity, when it comes to the education, when it comes to the workshops, Riboa,
simulation, the workshops across Turkey. These are very, very important. And most important part is EPAT has brought Turkish style of emergency medicine close to the English style of emergency medicine. That is very important, being proud of your language. And in spite of the language barrier, to bring Turkey up in the world map is something which is very important. This award is important, but most important is we come here to participate in this Congress, which is a world-class Congress. And award or no award, it doesn't matter because friendships are forever. So it's very, very important. And thanks to EPAT, and God bless you all always. Thank you.
Kıtalararası Acil Tıp Kongremize emeklerinden dolayı sekreteryamızı sahneye davet etmek istiyorum. Muhabbet İkbal Şaşmaz, Bahadır Taşlıdere, Yasin Yıldız ve değerli Kotar Azizli. Kongresi eş başkanımız Sayın Profesör Doktor Lucas Çarpak'ı sahneye davet ediyorum.
It's a great honor to be with you here again at this exceptional Congress in Turkey. From my perspective, emergency medicine and critical care teach us one fundamental thing, that the patient in the most difficult moments don't need only from us our knowledge, but also our courage and precision. And meetings like this give us great value. This is a place where the experience meets the science, science meets the clinical practice, the special type of practice which serves human lives. And I want to thank you, organizer, especially Professor Bashar, Professor Sagar, for this kind invitation, and for you all, I wish you the inspiration Congress, wise discussion and ideas which become tomorrow's standard of patient care. Thank you all.
13. Uluslararası Kritik Bakım ve Acil Tıp Kongremizin sekreteryasında sahneye davet etmek isterim. Serhat Örün, Mehmet Koşargelir ve Profesör Doktor Hikmet Anvarov.
konuşabiliyoruz iki rahatça. Şimdi tabii ki 22. defa oldu. Onlar da 13 oldu. 22. kongre bizim için çok zor, çok büyük bir emek, çok büyük bir marka. Şimdi bu kongrenin önce sekreteryasını buraya davet edeceğim. Sonra da başkanlarıyla buluşacağız. Önce sekreterya.
Sayın Cüneyt Arıkan, Abdülsamet Vural, Muhammed Ekmek Yapar, Mine Kayacı Yıldız, Ayla Mollaoğlu, Havva Seri Yiğit ve Atakan Yılmaz sahneye davet etmek isterim. Profesör Doktor Behçet Al sizleri sahneye davet etmek isteriz.
başkanlarımıza sunacağım ben. O 22. Kongre, 22. Ulusal Kongre başkanlarımız Profesör Doktor Mehmet Gül ve Profesör Doktor Zeynep Çakır hocalarımız. Menderes hazır, büyük emekler veriyor. Gel Menderes, bir de seni görelim. Evet. Adem Bey burada mı? Adem Bey. İsmail Şahin. İsmail Şahin. Buraya İstanbul Tıp Kitabı. Buraya rica ediyorum. Evet. Onun İsmail. İsmail Bey burada mı? Evet İsmail Bey. Değerli arkadaşlar, açılış törenimiz sona eriyor ama 3 gün boyunca çok çalışacağız. Kare kodlarla kimin hangi derse girdiğini bakacağız. %60'ın üzerinde derse girenler bizim için farklı bir statüde olacak. Onları bir şekilde değerlendireceğiz. %60'ı yakalamaya çalışıp biz mutlaka derslerde bunu takip etmeyi gayretinde olacağız. 23 Nisan 1920 tekrar kutlu olsun. Hepinize başarılı bir kongre diliyorum.